Remember, the content on our show is for information only.
It is not intended to provide medical or other professional advice.
Hello and welcome to Placebo, the podcast where we've moved on to what we're calling 2.0, or at least we're trying.
You may have noticed we had a small break with no episodes, but we're back.
And we're going to try a new format and just see how it feels. And so today, instead of us teaching each other about a topic that we might not have known so much about, we're going to review a recent news article that...
Still focused on healthcare.
Right, that was published about healthcare. We're going to see what the research says about it and also share our thoughts on the points that were made in the article itself.
Yeah. So we're hoping that this can maybe bring a more kind of personal or interesting take to some of the research and get away from being quite as dry as some of the research can come across, I think.
I'd agree with that.
Okay,
so the first article was found by Kaylin, and it's on the Washington Post.
Okay. So the title, I think it ran today, yesterday, around the December 4th, 2016. It's in their Health and Science section, and it's called, or the headline is kind of long, "A Doctor with a Bad Knee Runs into One-Size-Fits-All Medicine." And
before you listen to the rest, if you're interested in reading the article first, we'll give you this opportunity to jump out now and read the article and come back.
It's pretty short, don't be scared.
But if you want to just listen to what we have to say about it, you can stay and you won't probably miss any information.
I hope not. So I guess we should first maybe summarize the article before we kind of start talking about our thoughts about it.
Yeah, start with who it's written by.
Okay. So it's written by Eric Topol, and it seems that he is a doctor himself, a researcher, though. I don't know if he actually treats patients.
All right, so according to Wikipedia, which...
it's better than it used to be, I think.
Yes. Eric Topol is an American cardiologist, geneticist, and digital medicine researcher.
Digital medicine? What does that mean exactly?
I don't know. It seems like he currently works for Scripps, which is a large healthcare organization. Mm-hmm. And previous to that was at the Cleveland Clinic. It seems as though he has done a lot of research and won several awards in the field of medical research and doctoring.
So is his main focus, does it seem, in research, or does he treat patients at all? I wasn't quite clear on that reading his article here either.
I'm not sure. You know, the other interesting thing about him is that he seems to write a lot, including 3 books, one of which is a textbook. And you know what's funny is I think I've actually referred to several articles by Eric Topol in previous episodes that we've had.
So let's talk about the article. I think basically it's talking about his experience and journey of having knee problems and then having a knee replacement and his experience of the recovery from that.
Right? Pretty much.
So I would say he's a bit hard on the current medical system, or at least what he experienced.
Well, but as you can see from just the titles of his books,
yes,
doesn't seem to be surprising.
No, and I guess maybe the thing that is surprising is that he was surprised, at least how he presents it in this article, that he was surprised by his experience and really didn't seem to think for himself very much at all, especially as a physician researcher, in my perspective.
Right. It is weird because the article is written in a very dramatic tone, in my opinion. And so it makes me wonder if he's doing it on purpose.
To draw attention to his causes that he's interested in, perhaps?
Right, because he is obviously interested in advancing medicine in this patient-first, individualized care kind of way.
Yes.
He's written about all these digital ways that you can make medicine more personalized and...
Yeah. So anyways, I'll say that he talks about
Seems like it could be a strategy.
It could be a strategy. Not to put words in his mouth that he doesn't say, we don't know. But so basically he talks about how he has had knee problems since he was young because of a
Osteochondritis dissecans.
A condition that he's had all his life.
Right.
Plus he was...
Well, for a long time. I don't think that's diagnosed at birth.
Well, it said that he started having to have knee surgery when he was 20 and...
Knee surgery?
Yes, it said extensive knee surgery before he started medical school when he was 20.
Okay. So we don't know exactly what that entails.
We don't know exactly what the knee surgery was, but sounds like he tried to be active, but he was having to stop a lot of activities because of the knee pain throughout his life. And when he was 62, he decided to get a knee replacement with the advice of his surgeon. They told him that he was a really good candidate, that he was not overweight, that he was still fit. The only real risk would be a 1% to 2% chance of infection. And so he thought, great, I'm going to go ahead and get my knee replaced. And I would say then he kind of describes his experience with physical therapy and recovering from the surgery. And
right.
I would say I work and have worked quite a bit with people as an occupational therapist, and my physical therapists are my coworkers.
Right.
With people recovering from knee surgery and lots of other surgeries as well. What he describes is not what I consider typical. So it could be typical in a different area of the country, I suppose, but it's certainly not typical overall.
Yeah.
Yeah.
And although I'm not completely a physical therapist yet, I have just gone to school, and this is the experience that he describes. Well, some things seem to be what we learn, is not largely what we learn in school.
Okay, so let's talk about what he says. So he talks about how, he says, physical therapy typically starts at home the day after surgery. So two things that happen that are a little bit odd in that sentence to me is,
right.
Number one, most people don't go home the day after surgery with a knee replacement. In my facility, some people do that are moving really well, but in that case, they would not qualify for home care services.
Yeah.
You would go to a clinic and get physical therapy.
Well, so the things you're saying is that PT doesn't start the day after surgery. It should start day 0,
It does start day 0 in the hospital.
Which means it starts day of surgery.
Yeah.
So first point that's confusing there.
Second
point
I don't know what
is that if
he's
gone home the day after surgery...
That implies that he's doing very well.
And there should be no way that he, in terms of insurance or what the right medical step is next, he shouldn't be qualified for home health physical therapy.
That's right, because for any home health services, there's home health physical therapy, occupational therapy, nursing.
Right.
The point of home health services is if it is a significant hardship for you to get out of your home and to get to a clinic to receive those services.
And it's a medical hardship because transportation doesn't count. If you don't have a car and you can't get there, you don't qualify for home health services.
No.
You have to be medically hard.
It's not easy for you. So the fact that he went home the day after surgery indicates to me that he was doing really well, and so I'm not quite sure why he was receiving home health services at all.
And we don't know.
He says he received it for actually 3 weeks, which is really unusual. I think most people don't receive it for that long when they do receive it if they're doing well.
If you're having home health physical therapy and your therapist is seeing you regularly, then they need to. It would be my understanding that their opinion is that you are you need to be in home for physical therapy.
Right.
They wouldn't continue to see you past when you are able to leave your house.
Yes. And, he does talk about how he was having significant pain, and certainly he shows a picture in the article of his knee real swollen up, so it looks painful. So I understand if he was having trouble getting around, but it doesn't quite sync up with me to his description of going home so soon after surgery.
Right.
But again, it could be a different part of the country with different expectations. Anyways, he says that after 3 weeks, he continued his PT at a facility. He did the standard protocol. He emphasizes that they were pre-printed sheets of daily exercises. Seems like he didn't like the pre-printed aspect of the sheets.
Again, as biased as individualized medicine, which we find out later in the article is probably his whole point of writing. So this is a point that he's drawing attention to because of the greater, the greater viewpoint that he has for writing this article.
So, and I guess my perspective pre-printed handouts is that I certainly use them at times with patients, but I will select the different exercises or change the frequency or whatever as I think appropriate for that patient. So just because a handout is pre-printed doesn't mean I follow it exactly as written, the same for every single person.
Yeah. And, but the same thing is also true for doctors, which I'd agree. It's you want to, make it relevant to each person. But right now, the current practice, recently I had a sinus infection, went to the doctor and got a pre-printout on what a sinus infection was and what I should do for my care. And you still see the doctor and they tell you what they think and what they think you should do. But they clearly didn't just write up that recommendation and explanation of my condition and then give it to me. That was already printed.
Right. I think what is it's a little bit tricky to me here is that a lot of I think everybody thinks that they're special, right? Everybody thinks that there's unique things about them,
as we should,
that are special, which is true.
Everyone's told that from childhood.
From our generation anyways. But I would say also there's a lot of similarities between people. And even considering the individual differences, considering he's had this other condition that has caused, knee problems throughout his life. There's a lot of similarities to be expected in the case of recovery from the exact same surgery.
Right.
So just because you're an individual and you're different doesn't mean that most of the time starting out with a similar program and then modifying it as needed doesn't make sense.
Right.
I don't know.
Well, and the thing is, too, he's writing about, as he mentions, a very common orthopedic surgery.
Very common.
One that surgeons are incredibly skilled at doing these days.
They do a lot of them.
And I was hearing, if someone had a knee or a hip replacement 30 years ago, you might have stayed in the hospital for weeks.
I mean, even when I started working, and I've only had experience in 2 different hospitals, but even 6-7 years ago, people stayed 5 days, 6 days even.
But that's not how it works anymore.
No, I would say most people with a knee replacement might go home. I would say the average would be in the morning the second day after surgery. That's about normal.
Yeah.
At my facility, but it might vary at different places again. So anyways, he talks about how he goes to PT. They're putting him through their standard exercise protocol. He's having really severe pain. He's telling himself that, no pain, no gain, and he says that he's pushing himself so hard that he's screaming while he's doing his exercises and trying to bend his knee. That he's having severe swelling and his range of motion in the knee isn't doing very good. So his doctor told him to do more and more intensive therapy.
So I guess we should talk about this now.
Yeah, okay.
So he writes in the article that one of the main goals of physical therapy after a knee replacement surgery is to make sure that you maintain a normal range of motion in your knee.
The idea being that if you don't move it very much as it heals, you'll develop scar tissue and then you won't be able to move it well in the long run.
Right.
Yeah.
And this is commonly known at this point, that is the goal or one of the goals of PT after surgery for knee replacement. Although what he's described as no pain, no gain is not what they teach in school.
No,
right.
It really isn't.
So he seems to,
whether he's in his 60s, maybe that was what he learned
right
when he was in medical school.
And maybe he was seeing a therapist that, was also educated, a while ago.
In the past, who knows?
If I would imagine that if either...
Although your responsibility as a clinician, both him and the PT, is to stay up to date, so
right.
I don't consider that too much of an excuse.
No. Yeah, so it would seem, because we learn in school that in the past, what you would do for a knee surgery is just you would, have that attitude for it. And that the goal was just to push through whatever pain you had and get that range of motion. Of course, that's not what we learn now.
No, he describes PT as physical torture, which I've heard many patients say to me, and it kind of hurts my heart when people say that, because that's not what I want. I'm not a physical therapist, but that's not what I want people to think of for rehab, and that's not what I want
their
impression to be.
Well, and I think
it's really sad.
right, and kind of the main idea behind all this for me is that the science of pain management,
as we've talked about on multiple episodes,
pain medicine has changed a lot, and there's so many problems with either the mentality of no pain, no gain, the mentality of calling it physical torture, because of course that's creating an association in your brain that physical therapy is torture, so of course it's going to be painful and awful.
So I always try and correct people gently when they say things like that.
If he's going to name PT physical torture and continue to call it that so much that he remembers it and writes about it in an article, I'm not entirely surprised that he had a really painful experience, because here he is associating PT with pain and torture continuously.
Yeah. Now he also talks about how at the end of each session, the therapist is forcefully bending the knee as far as it could go. The swelling is increased. The knee turns purple, giving him profound pain. In many occasions, I could barely walk out of the facility. So there's a lot of issues going on here.
Right.
Right? I would say on both his part again and on the physical therapist part that was treating him, there's a severe
misunderstanding,
ignorance of the symptoms. I don't even know what's going on. Again, I'm an occupational therapist, not a physical therapist, but I do work with people. I do exercises at times, and I do things that could cause pain because I work with people after surgeries or things like that. But I always monitor how they're feeling, change what I'm doing to the appropriate level to what they're able to tolerate, because as we've talked about with pain, causing severe pain and inflammation is not going to be helpful in his recovery.
It's only going to perpetuate the problem.
Right. When you repeat those cycles in the brain, right, you're just strengthening and strengthening the pain loop. Right.
Yeah. It's a feedback loop, right?
Yes.
So if he's continuing to come to PT, which he's calling torture, they're causing pain, and he's feeling pain, it's just going to keep increasing. It's not going to get better.
So I'm really sad for everyone in this situation.
This is how chronic pain starts.
And I would say for any listeners, if you're getting PT and they're causing worse pain, there's a problem. That's not what should be happening.
Right.
There's a difference between, some muscle soreness or something because you were doing an exercise and you're tired versus he's describing
screaming in agony.
Yeah, or a knee turning purple and he's unable to walk. That's not helpful therapy.
Right.
Yeah. So, sorry, we're on a bit of a high horse in this episode, I think.
But that's also why we're kind of excited about Placebo Podcast 2.0.
Yeah.
Because we think it'll be...
I hope it can be a little more...
exciting.
This article is dramatic, but maybe a little more drama in the episodes, too, in a fun way. Okay, so we're going to move on down the article here. He talks about how he can't stand or sit, he can't sleep, he's crying all the time, I'm a little bit concerned that this gentleman is a doctor and that he doesn't, and a research doctor, and he doesn't think logically about this.
Yeah, well,
I think maybe he
no one
for
thinks
yourself,
logically
right?
all the same for
yourself,
themselves,
especially. And I think maybe he just is maybe panicking a bit and not thinking about it logically, but panicking and thinking, I just got to do the exercises more and more and more. This is the only way, or something.
Well, again, not surprising. He's in this feedback loop of painful therapy, and
although again, with his background of being someone advocating for patient-centered care, you'd think he'd be asking for that for himself.
Yeah, why wasn't he advocating for it earlier?
I don't know. He talks about how his
we're criticizing, obviously.
I am criticizing him, but
this is a short article. It's an opinion piece, and he's making a clear point. So there's a lot of detail left out that perhaps could be explained better if we knew the full story.
Certainly, and I guess I don't know this man's full history or story. I only know what he's presented in the article.
Right, which is all we have to go off of, really, because he's trying to make a point with this article, and he doesn't seem to be representing the small amounts of detail that he's provided don't seem to be appropriate.
Anyways, he talks about how his wife found a book called arthrofibrosis, which is a complication occurring in some patients after knee replacement. He was discouraged anyways by the book about arthrofibrosis because it said basically that they recommended aggressive physical therapy, which he's already doing, he feels, and is not helping.
Mm-hmm.
So anyways, he's getting really, really desperate. He says, and I think maybe you're right as we're talking about how he's not thinking logically for himself, because he talks about how, he advocates for evidence-based medicine, which we certainly advocate for too in our podcast, right?
But he clearly doesn't advocate it for himself.
No, but he did a lot of things which there are limited clinical trials or things that show, questionable benefit, if any, because he just was, I think, really frustrated and not sure what to do. So he talks about acupuncture, which has some results we know, but not necessarily in this setting. Electroacupuncture, ointments, the cold laser, supplements. So he would just get worse. He went back to his surgeon, and his surgeon basically said, he hopes that it will settle down. He could do another surgery and take out some of the scar tissue.
And that's not entirely surprising to me either.
No, because the surgeon's job is to recommend surgeries, I guess. I don't know.
Well, the surgeons, as people that, we're not working closely with surgeons.
Not necessarily.
But their job is surgery. I
Yes.
would expect them to be excellent at performing surgery, knowing when surgery is needed and not needed, and the close care around surgery. But his job is not to know about rehabilitation, the rehabilitative process.
No.
And there are reasons that there are other specialties of both doctor and other care providers like physical therapists, because their job is to know about that process. So why is he going back to his orthopedist whose job is not to know about that process?
Right. I think people expect that the surgeon will know, though, because maybe his perception is the problem started with the surgery. I should go talk to the source of the problem.
But again, as he's someone who is intimately, entwined into the healthcare system. He should know it's not the surgeon's job to know about that.
I don't know. I can't explain all of it. Anyways, he says that he had a friend who recommended he see a different PT. He talks about, in particular, how this person had a lot of experience.
The point to me here is why else would you bring up the person's experience if you thought that it didn't matter for their health care?
Mm-hmm.
So
what do you mean? Let's see.
Well, I think he's bringing up the experience as he thinks that this physical therapist was so good, in part because they had 40 years of experience. And
I would say people with more experience know more, usually,
hopefully. I think that that's true, but I also think that it's a fallacy to use that as a reason to assume that they're providing better care.
That is true.
Because they're experienced,
Well, and I would say, like I said, theoretically, someone should have more knowledge and experience if they've been working hard their whole career on increasing their knowledge and experience, but not everybody necessarily does that.
But it also seemed like he had a physical therapist earlier who was only aware of, or not able to implement more current treatment strategies. Mm-hmm. So anyways, he felt that this PT did a better job at taking a history. He felt like she understood his background a lot better than previous care providers and was able to base her, protocol with him on his personal background versus his just his surgery and not considering anything else. Right. So what he says that she recommends for him is a pain-free exercise program, which I would say is, of course, incredibly vague, but very much more on track with what is probably recommended for anyone coming out of any surgery at this point. So while he thinks it's specific to him or specific to his situation, that a pain-free exercise program probably covers 99% of every, should.
I mean, and I would say, like, for people fresh out of surgery, this is clearly several months out for him now at this point. For people fresh out of surgery, certainly there's going to be pain when you do some movement of the part that had surgery, right?
Right, but I suppose what he means there is
it always should be tolerable.
The therapy is not causing more pain.
Right. I tell people it should never be intolerable. If it's intolerable, then something needs to be changed. You need to be doing something differently. You need to be...
Because it's not therapeutic if it's painful, and then you just perpetuate this cycle, which you can read about in his article.
We use, the pain scale, which people kind of hate. 0 is no pain, 10 is
the pain scale's awful.
the worst pain. I love that. Have you seen the one with the faces?
Mm-hmm.
Yeah.
The interesting thing about that I've never thought about till now is you've just said, well, like, people in pain are not necessarily logical, especially for themselves. And a scale of 1 to 10 is like, how can you be more logical? You know?
And I get people saying 13, 13!
Yeah. But of course you can't be logical when you're at
No. So I understand you're having high pain.
So
but that's off the scale. 10 is the highest.
It just doesn't make sense.
So anyways, yeah, so we recommend, you're not getting above a 4 or so at the maximum. You shouldn't be getting past that. So if you are, something needs to change. You need different pain medicines. You need to be icing more. You need to be doing less in the exercises. Something. You're walking too much.
A 4 is tolerable, but of course you shouldn't be screaming.
Right.
That's not a 4.
You shouldn't be crying like he's describing.
Yeah.
Anyways.
His pain levels are significantly more than we would want during a therapy session.
Right. The other thing that he mentions that the new PT recommended was anti-inflammatory medications. And this really caught my eye because I don't know exactly the rules for PTs because I'm an OT, but we cannot recommend medications.
It's not recommending medications.
No.
So here's what they say. What we've been taught in school is if you're working in an outpatient clinic,
this is.
It is your job to ask for a medication list. It is your job to know all the medications that you're taking, and you absolutely should be putting them into a trusted database to search for interactions or doses that seem inappropriate.
Okay.
It is not your job to then tell the patient, hey, you have an interaction between these two medications. It is your job to then contact the physician in the way that your clinic does. Also to tell your patient that you're contacting their physician because of the medication list they've provided.
Yeah.
It is not your job to say, hey, it looks like you should take more ibuprofen because you're not taking any right now and you have some swelling. We all know that ibuprofen is an anti-inflammatory.
Right.
But it's not within the legal scope of the physical therapist to say you should be taking it.
Because our education is not focused on medications, and he may be taking other medications that, could interact with that, or he's had a bad experience with that in the past and you don't necessarily know that, or whatever. Right. Just as it's not his surgeon's role to know a lot about the rehab process, it's not the physical therapist's role to know a lot about medications and prescribe them
in a way
or recommend them.
Right, yeah.
It is good to understand what they are and how they could affect your patient if they're taking them.
Right.
Right.
So, but again, the point here is that he's written a vague article that's providing points.
I hope this podcast isn't too angry for people.
Well, maybe it's more fun. I don't know.
We're riled.
Yeah. He's written a vague article that's only bringing up points that are completely inappropriate, for the course of care that he should have got. And
again, as a doctor, I guess it's not his job to know what the scope of practice is for a PT, but I would think that might ring a bell for him. If as a doctor, you're one of the very few healthcare professionals that can prescribe medications. Yes.
You should know that others can't.
And even if these are over-the-counter medicines, I still believe it's not our role to be recommending people take them or not.
Yeah.
Yeah. Anyways, he thought this was great because the plan was individualized, which it really should be for anybody. I do agree with that.
And as the tone of his article suggests, it was a dramatic turnaround.
Yeah. He also enjoyed her handwritten instructions instead of pre-printed handouts, which I thought was interesting because I have a couple thoughts about that.
So do I. I have more than a couple thoughts about that.
So my thought is, do you want to go first with your thought about the handwritten exercises?
Sure, I'll start. Okay. My thought is very, very unprofessional.
Yes. Gosh.
So maybe, but again, he's suggesting individualized medicine.
Yeah.
Maybe the therapist thought, this is a guy who's gonna enjoy a handwritten, set of exercises for me.
And if so, she read him very well.
Right. So, and it's possible that she did, if the results of
perhaps he was talking, true, I would guess, based on this article, that he may have talked to her about his frustration and feeling like he was not treated individually in the past.
Right.
And maybe she made that call. I don't know.
I think in general, it is obviously this whole thing that we're talking about now is paying attention to who you're seeing. But if you were to just ask me written or printed, exercise sheets? The answer is obvious. Should not be written.
No.
You are representing yourself as a healthcare professional, and you're representing your business that you work at the outpatient clinic. You're representing the profession as a whole.
Now, one thing I wonder is he did mention this PT's years of experience. So she's 40. She's 40 years of experience. She's probably in her 60s at this point.
Right.
She probably went to school at a time, certainly went to school at a time when there was not computerized documentation, when you did most of your work by hand.
Right.
So it's coming from a different perspective.
And he's also in his 60s.
So maybe this is the thing. I would never, like when you're in school, for example, you would never turn in a paper handwritten. That's very unprofessional.
Yeah, if I tried to turn in any homework assignment handwritten, it wouldn't even get looked at.
So maybe this is from our perspective as a younger people.
Oh, it definitely is.
But I would say, yeah, I all of our things are printed out, and sometimes I will say that, we have them saved in our computer system. Maybe I want to make a modification to the exercise program for the person. I'll open up the document, change it for that how I want it to be for that person, and print it out for that person. And then, not need to have a handwritten anything.
Right.
Plus, it's easier to read for people.
Yeah. I mean, this person works at an outpatient clinic.
Yeah.
There is absolutely no reason that they don't have a software program either built into their EMR or separately that they've purchased that has every exercise they could want and allows them to put it together in a professional-looking sheet of exercises, individualized for him, with their own recommendations of how intense to do it, how many times to do it, when to do it, what equipment to use. I mean, this is...
The other thing that kind of stands out to me is maybe, I don't know, on a separate perspective altogether, is that when you have pre-printed handouts, or at least mostly made handouts that you can just modify slightly and then print, it's a big savings of time compared to writing them out individually per that person. So for me, that's more time that I can spend on patient care and less time making handouts.
Well, that's incredibly true, because an outpatient clinic that I spent time at during my physical therapy education used a software-based exercise prescription program. Now, it was what usually happened is there would be an eval, which would last about an hour. In reality, that eval lasts 45 minutes, and the last 10 is the therapist leaving the room, going to figure out which exercises they need to prescribe for this person, and then creating a document for them. So, as a patient, it should be that
you're just kind of sitting there for 10 minutes.
You would prefer that your therapist is faster at making you an exercise sheet. So maybe, again, this was a choice that she made because she wanted to make an exercise sheet quickly without having to refer to maybe a software program that her clinic has that's not very fast. She didn't want to waste this man's time, which is what we want when we're printing out pre-printed exercise.
Right.
Because we want to spend our time with our patients, being as therapeutic as possible, instead of letting them sit in a room for 10 minutes while we have to go print out their exercises on their individualized sheet.
So anyways, he kind of wraps it up by saying, everything did really well after these exercises. He did great. The swelling went down. The range of motion improved. He finishes by saying, I had been rescued, which is, again, a really dramatic statement, I feel like.
The whole tone of the article is incredibly dramatic.
One more thing, I just can't let things go in this article, is that he says that the therapist was texting him every other day to ask how our knee was doing. And a couple of things strike me in there about barriers.
Yeah.
What are your thoughts about that? I don't know about a clinic, but in a hospital setting, that is a big no-no, unacceptable.
I don't know about a hospital. I think if your patient is in the hospital, then they're in the hospital, and you can see them whenever you want. So I think this doesn't strike me as a problem.
It doesn't. That's interesting to me.
No. Unless
she has a work phone, it really strikes me as a big problem, because then she's giving her personal number out.
I would imagine. So let me tell you what I know. I know there are several EMRs for outpatient clinics that I can think of one in particular, but I know there are at least several that are new companies. They seem like new tech companies. They're not like these big clunky hospital EMR things. They're like actual software.
Should we say what EMR stands for? Because you've said it several times and maybe people don't know.
I think you did. Electronic medical record.
Oh, okay. I don't know.
I think you did earlier.
Maybe I did. I'm just so worked up.
So they're not like big clunky like hospital EMR things, which are like these softwares that seem like they've been around since the 90s and not updated very much.
Yeah.
And they have to do a lot, so they're just not very. There's all sorts. That's a whole other thing, right?
Yeah.
So these look like new pieces of software, like something that maybe Google wouldn't be
ashamed of.
Yeah, right. So I know that there is software that you put in the patient's phone number, and it will text them reminders of when their visits are. So if this patient has said yes, texting is the best way to reach me, then it's all internet based, the sending of text messages. It's all part of what you get pay for using this service. We'll send them a message and say, hey, you have a appointment at this clinic tomorrow. Are you going to make it? And that's part of the reason for that is because obviously clinics need to make money. And if you're going to cancel your thing and haven't had the chance to tell them yet, and then, maybe you weren't going to, but this text is like, oh, I can just respond, yes or no. And then they can schedule someone else if you're not going to make it,
That's different to me, though, than checking on personally, how are you doing with your exercises and stuff?
I don't know that that's true because a lot of what my, knowledge of how we're evolving into this kind of telemedicine thing is that we should be available to our patients in the way that they choose to be or want to be available to us. And clearly he was interested in texting, which is also weird because he's also interested in handwritten exercise sheets.
He's kind of going on both sides. I guess he just likes the personal touch either way.
Right. So I don't think this is out of the range. I think that
I think as long as it's as you described through some sort of work phone or
I imagine that it would be there's
service
because it's likely that that's the policy at their clinic, that we send you send a reminder message that's probably automated in some form or another. Like you can maybe add a little bit to it, but it's maybe it sends a message to them every 3 days after their session, exactly 3 days after their session, and you just when you're writing your note right after you see them, you put in that message. It's going to send it 3 days later. And then as it comes back in, the EMR will say, hey, someone's responded to it. And you can check that. So this is built in. I think that
okay. Well,
I don't think that's inappropriate, and I think it will be a larger part of care, especially as technology advances.
Well, okay.
Right now, I don't think we're not billing for it very well, but I think that's normal.
How billable it is. Well, okay. I appreciate the explanation. I take back my criticism of that.
I don't think she's using her personal cell phone
that's
to
good.
Text him.
That would be no. Don't
to text
do that.
him about his knee. Yeah.
Okay.
Because you're right. I mean, we're trying to be professional. I think that this is a developing area of patient care, but I think it is one that exists in a professional manner and that seems appropriate to me, is in line with things that we've learned in school recently and probably with people's upcoming preferences towards communication.
There you go. Well, and I'm not as familiar, as I say, with the clinic, so that's good to know.
Right.
Okay, how does he wrap up the article? His knee is fixed. He's feeling a lot better now.
Dramatic historical quotes.
Basically he talks about how some people do well with the intensive PT, other people it will backfire and set up a cycle of inflammation. He needs a different protocol. Mike?
There's a plug for his own career.
Yeah. He talks about his career and a grant that he's been awarded for researching
precision
medicine, also known as individualized medicine, which is like using genetics to determine the correct medicine for someone.
Right.
And I've heard of this for cancer treatments, I think, in the past.
Pretty much everything these
I believe
days.
Jimmy Carter received a cancer treatment based on genetics, and it was successful for him.
Right. Well, you hear about this a lot now. Pharmacogenomics is the whole study of taking someone's genome, figuring out which medications are going to be most effective to them, and then giving them those medications. And
I think that's great.
Right.
I think that's a really interesting field and certainly one that needs to be further researched. So I'm glad that he's researching that. I'm I still remain disappointed that he wasn't able to make the connection as a doctor that, oh, this is too aggressive, I should do less, and like share that with his physical therapist or more quickly find someone else.
Well, not necessarily do less, but do something differently, right?
Well, maybe less aggressive exercises,
right.
you know, because clearly he was setting up a cycle of pain and inflammation, and, you know, that could be stopped, and it was actually pretty simple.
Right.
To do.
And even after months and months of creating that cycle and feedback loop, he was able to turn it around.
Which is great. Not everyone can.
Fairly quickly.
Yeah.
Right.
So anyways, yeah, I guess my other point would be for people, that might be in a similar situation to think about what can be changed. Don't just blindly trust the opinion of the one or two people that you've seen, I guess, too.
Yeah. Well, what's lacking here is that the patient needs to be an advocate for themselves, right?
Yes.
And
it's hard to do sometimes.
But as an experienced physician, he should know how to be an advocate for himself.
So, and it's hard for people, especially people that maybe don't have his background, that don't ever work in healthcare or have any knowledge or experience with it, to be an advocate, because you don't even know.
But you don't necessarily need to know what to do next or what other options are available. But you do need to ask why.
Yes.
And it doesn't sound like he necessarily did, because if you're in pain
and crying and screaming
and you ask them why and their explanation seems questionable to you or just makes you have a gut feeling of it's not quite right, then maybe you should investigate that further instead of just blindly accepting physical torture.
So he says he's really lucky that he got that. Please don't call it physical torture. He's really lucky that he got that expert referral, or he'd still be suffering. You know, and I'm just sad that it took that he didn't find the way to do it much sooner, and that he did have to suffer that long, because I don't think it was necessary. You know.
But overall, though, we want the best for our patients. I'm not sure how. You know, I don't think this is a unreasonable, he wants the healthcare system to be better. And
it should be, and it can be.
This article is clearly written to make people upset in one way or another, whether it be the way that we're upset or whether it be just someone, upset that he had to suffer for so long and that it was hard for him to find good healthcare.
So I guess I'm upset because I actually agree with his point, is that healthcare should be individualized and we should be focused on the patient and not just as a diagnosis or something.
Right.
But I disagree with how he presented it a whole lot, because I think it's a little disingenuous and overly dramatic.
Well, that's definitely true.
There are certainly lots of case studies of people that would be, I don't know, more truthful.
Yeah. Well,
I guess it's truth of his experience, but
it is. Yeah, I don't know. I feel weird about it too, because it seems like there are ulterior motives too with his mentioning of winning his grant and this research he's doing. I just can't
believe he went through this for 3 months if it was that bad, and he didn't think about doing something different for 3 or 4 months at least.
Yeah.
But he does show the picture of his knee, and it does look real swollen. Also, I think one other thing I would add is that as a patient, it can be hard to be an advocate for yourself because you are in distress.
Right.
Sometimes,
Well, we mentioned that earlier. It's hard to be logical, especially when you're the one living the situation, right?
So if at all possible, I would recommend, if you have anything going on healthcare-wise, or if you have a friend or a family member, to be there as a partner for them, or to have someone be there as a partner for you to advocate and to help listen and stuff like that, because it can be hard to take it all in yourself.
Yeah.
It can be really helpful to have someone there with you. So, he ends up with his nice 1927 quote, "The secret of care of the patient is caring for the patient." Was that good?
Yes. I was blown away by your insight.
That's by Francis Peabody. And that's great. I agree with that. You should focus on the individual. I think that's the most important thing. So I've come down to that same point as this person after arguing with him through the whole article.
We're interested to know what your thoughts might be on this article. Does it, as if you're in healthcare or not in healthcare and just interested in it, how does this article make you react or feel?
Yeah, if you've had a knee replacement or similar type surgery. Obviously, we work with people or know people that have, but we haven't had it ourselves. So
clearly, we were filled with feelings of frustration from this article.
What did you feel? And also, what did you feel about this format? We're hoping to continue with something similar, maybe backing up or talking about articles and from the popular press versus the scientific press,
right?
I guess, and then using research and our experience of healthcare to discuss them from our perspective.
Right. If you enjoyed this episode, please share us with a friend or give us a rating on iTunes.
You can also visit our website, placebopodcast.com, for show notes or to send us any suggestions or feedback.
You can also find us on Facebook or other social medias.
Oh, I was going to say what we should do is, since we have an article with a normal link, we'll put the link up on our Facebook. How about that?
Sure.
Okay.
Yeah.
Thank you to James Aiken for our music.
And thank you to all of you for listening. We'll be back next week with a new episode.
Really, next week.
Goodbye.
Goodbye.